This is Lecture 6, which will cover the influence of hormones on brain and behavior, as well as psychophysiology methods. It corresponds with Chapter 6 and Chapter 7. For Chapter 7, I want you to skim the material of the textbook and rely mostly on the PowerPoints, and only read, within the textbook, only read sections 1 through 4 in Chapter 7. Homework 7 is due this upcoming Sunday at 11 p.m. And just a heads up, we're going to be covering 2 chapters per week from here on out. It's a lot of material, and I'm going to tell you kind of what to focus on and what to skim over or skip over. It's just because the summer session is a condensed session. We have fewer weeks than the normal semesters, so we do have to cover a little bit more material per week. And I like to give the first few chapters a little more time, because I think especially if you haven't had a biology or a chemistry course recently, those can be a little more challenging. So we are going to be covering 2 chapters per week, but I hope that those chapters are going to be a little easier to digest than the first few chapters. Your recommended reading for this week is an article detailing some of the similarities neurobiologically between drug addiction and romantic love. So in drug addiction, a large amount of research implicates the dopaminergic mesolimbic pathway, specifically or particularly the ventral tegmental area, the VTA, and the nucleus accumbens. And a smaller body of research has also noted that this area is activated, these pathways and these areas of the brain are activated when somebody is in love, especially with a new romantic partner, so kind of like the intense first stages of love, as compared to a friend. Essentially the brain of someone who is intensely in love with another person is somewhat similar to the brain of someone who is literally addicted to drugs. Now, we shouldn't take this too far and say that like love is literally an addiction, or that it's the same as drug addiction, but it is noted that a lot of the behaviors associated with neuromantic love are kind of common to drug addiction. A lot of times people only want to spend all the time with that person. Breakups can have some similarities to withdrawal, and in fact, a breakup during this intense love phase is associated with it is similar neurobiologically to withdrawal from a drug. So take the research kind of as it is, but it's an interesting comparison.
Okay, so starting with section 1, most of this is going to reflect the book, but there are a couple areas where I deviated because I either don't necessarily agree with how the book frames something, or I wanted to give extra information. I tried to make this a bit more information heavy this chapter, as a lot of you had mentioned that you were particularly interested in how drugs affect the brain and also how hormones affect the brain. So to start out, psychopharmacology is the study of how drugs affect the nervous system and behavior. Psychoactive drugs are any substance that alters mood, cognition, or behavior primarily, and this is both like medications for mental illness, as well as substances that are taken for recreation. Most drugs do affect multiple neurotransmitter systems and different parts of the nervous system, including different areas of the central nervous system. We'll try to simplify it in this chapter and talk about the main neurotransmitter systems that are targeted by individual drugs. There are individual differences in how drugs affect a person, so obviously someone who has a bigger body mass is less affected by the same amount of a drug as someone who has a smaller body mass. There's some indication that different genders may respond to drugs differently. Genes actually have kind of a bigger effect on how people respond to drugs than one might expect. Age, and then expectation of drug effects. So whether or not you expect to be intoxicated by a drug, or the expected effect of the drug can change how the drug affects you. Importantly, there are many psychoactive drugs that we don't understand the mechanisms for. In fact, for most of them, we don't have a thorough understanding of how they work in the brain. A lot of medications, such as antipsychotics for schizophrenia, antidepressants, we have some idea of how they work, but not a detailed understanding. We just know that they do work. So there are several ways that drugs can be administered in the body. Injecting just straight into the bloodstream. This is a very quick way to inject medications or drugs. Lower doses are needed because it's going directly into the bloodstream. People can also consume drugs orally, like through a pill. This is typically the safest and the most convenient. You don't need extra syringes or anything like that, but it still can be very dangerous. People can easily overdose through taking pills. People can inhale drugs, so think like tobacco or cannabis, where it's absorbed through the lining of the respiratory system, and then patches, where drugs are absorbed through the skin, so nicotine patch is an example of this. The more barriers there are between the route of administration and the brain, the higher the dose is, the dose of the drug is needed. And just a reminder of the blood-brain barrier, which we talked about before. This is a barrier that's created in part by glial cells that prevents toxins in the blood from easily accessing the brain. This is one way of keeping the brain safe from, for example, if you were to eat something, like if you had food poisoning, you wouldn't want those toxins getting into your brain. Instead, you get sick, physically sick, but at least your brain is not affected unless it's a very serious toxin. But it can also, the flip side of this is that it makes it difficult to administer medications in the brain. Okay, so just a reminder of what agonist and antagonist is, and here's a little picture. So in terms of acetylcholine, an agonist of acetylcholine is black widow spider venom, so that promotes the release. It increases the transmission of acetylcholine. Botulin, which is the toxin from botulism, is an antagonist of acetylcholine, so that prevents or decreases acetylcholine release. Nicotine, as we talked before, is an agonist of acetylcholine, and so on. Their postsynaptic receptors are typically designed for certain endogenous neurotransmitters. So, for example, there are acetylcholine receptors, but these can be activated by other substances that have similar chemical structures. So some acetylcholine receptors, specifically nicotinic acetylcholine receptors, can be activated by other substances that come from outside the body, such as nicotine. Tolerance is a decreased response to repeated exposure of a drug. You're probably familiar with this idea that the more alcohol you drink, if you're a chronic drinker, you need more alcohol to achieve the same level of drunkenness over time. There are three main types of tolerance. There's metabolic tolerance, where enzymes in the liver, blood, and brain that are tasked to break down alcohol, these actually increase with chronic use. And as a result, the users, if someone is chronically using alcohol, they metabolize it more quickly, and this reduces the effect of alcohol, so they have to drink more to get the same effect. There's cellular tolerance, where brain cell activities just adjust to higher levels of alcohol in the blood. And then there's the more psychological, learned, or functional tolerance, where a chronic alcohol user gets accustomed to the feeling of intoxication, and so they don't show as many of the outward signs of intoxication, so they might not slur their words as much, might appear normal. You might have heard the term like a functional alcoholic. A lot of times a chronic user will not notice the effects of alcohol as much as well. And you might note that tolerance resembles habituation. So the flip side is sensitization, which is an increased responsiveness to the same dose of substances over time. So where tolerance is more likely to happen when somebody is chronically using, like using every day, sensitization is more likely to happen when use is intermittent, so there's more time between uses. The book outlines a study in which rats were injected with amphetamines and showed increased behavioral symptoms of amphetamine, so increased motor activity, for example, each time they were injected with these intermittent doses. And what's happening at the cell is that more dopamine is being released into the synapse as the rats are becoming sensitized to amphetamine. Other things that are happening in the cell is that there are more dopamine receptors, so more opportunity for dopamine to have an effect on the postsynaptic cell, and there's blocked reuptake of dopamine, which means it stays in the synaptic cleft longer and has more opportunity to bind to receptors and have an effect on the postsynaptic cell. Drugs with similar chemical structures can actually have very different effects, and drugs with different chemical structures can have similar effects, which makes it very complicated to categorize drugs. Any one drug can affect multiple systems, although, as I mentioned before, we're going to try to make generalizations based on the main behavioral aspects of psychoactive drugs. And notably, drugs can typically have 2 or 3 names, so they can have a chemical name, and then often they'll have a generic name too, and then a brand name, and they can often have several different brand names. For the most part, when I was talking about medications in this next part, I'm using the brand name just because I think it's a little more recognizable to most people. So these are all the groups of psychoactive drugs. Your book used grouped them by the behavioral characteristics. So there are many different ways to group them, but this is how your book chose to group them, so I'm going to follow that grouping. The first group is anti-anxiety or anxiolytics and sedative hypnotics. In low doses, these anxiolytics reduce anxiety. In medium doses, they're more like they sedate, so people might feel drowsy or tired. In high doses, they can be used as anesthesia or even cause coma if given too much. In very high doses, they can completely suppress the nervous system and people can die. And these drugs have a very high potential for addiction. So anxiolytics include benzodiazepines or benzos, and this is like Valium, Xanax, Klonopin, lorazepam. They're used for anxiety, so general anxiety disorder, phobia, etc. Sleep issues, helping people get to sleep, and then before surgery to help people relax. Sedative hypnotics are in general considered more dangerous than anxiolytics because high doses are more likely to cause death or serious injury. Prescriptions of these drugs are very highly regulated in most states. According to some of my drug-addicted patients, there have been some new regulations in Hawaii recently making it even more difficult to get these prescriptions. Overdose is more likely to be fatal compared with benzos, and sedative hypnotics include barbiturates. That's kind of a major category, and these are typically used as anticonvulsants for general anesthesia, for very severe migraines that are refractory to other treatments, and in the case of euthanasia where that is legal, or I suppose where it's not legal too, this is sometimes used. So examples of this are like Amitol, which is a sedative, Luminol, which is an anticonvulsant or a medication to help treat seizures, phenobarbital, secobarbital, and secobarbital is the one that I think is most commonly used for euthanasia, at least in pets, and I think in people too, in the case of euthanasia of a human. There's a compound called sodium amytal, which used to be used, I think, like back in the 50s. It was considered like a truth serum, and really it's just like a bit of a sedative, so it reduced inhibition, kind of slowed thinking, and made people less able to be lie and more likely to be disinhibited and tell the truth. And sedative hypnotics include alcohol too. So the official name for alcohol is ethanol, and you might see it abbreviated as ETOH. Other anesthetics include GBH, which in medicine, for medical reasons, is used for narcolepsy treatment sometimes. In small doses, it can be used recreationally as a stimulant and an aphrodisiac, but it's most commonly known as a date rape drug. So in larger doses, it can cause extreme sedation and memory loss. It's not easily detected in urine, so in the case of people suspecting GBH in a date rape case, a urine test will not be effective soon after a reported rape, but it can be detected in hair. So in the case of investigation of a date rape, sometimes hair can be used to figure out if GBH might have been involved. And notably, it can cause a salty taste in drinks. So if you ever find your alcohol to be extremely salty, possibly beware. Dissociative anesthetics cause dissociation, hallucination, euphoria, so some kind of psychedelic experiences. And these include ketamine, which is also known recreationally as Special K, which causes memory impairment, paranoia, agitation at its worst. And it's actually an animal model for schizophrenia because its tendency to cause dissociation, hallucination, and paranoia. Then phencyclidine, which is PCP, or known by its street name angel dust, used to be used medically, but is no longer common. It's pretty much exclusively a recreational drug these days. And nitrous oxide, which is also known as laughing gas or whippets, is used commonly in surgery and dentistry. And it's also used in food containers like whipped cream cans to propel the food. It increases norepinephrine transmission, which later on increases endogenous opioid release. So the neurotransmitter action of these anxiolytics and sedative hypnotic drugs, the GABA A receptor is a common target. GABA, if you remember from previous chapters, is the main inhibitory neurotransmitter in the central nervous system. Makes sense, GABA, that these sedatives and hypnotics, which have this dulling and sedating effect, would act on the inhibitory neurotransmitter. So sedative hypnotics in particular increase the time that the pore is open, allowing chloride, which is a negative ion, to come through, and benzos just increase the frequency of the pore opening. And this influx of the negative ion creates a more negative charge in the cell, which makes an action potential less likely, so it just decreases neuronal activity. Taking any of these substances together, benzos, alcohol, barbiturates, can be very dangerous because they have this additive effect. They all have the same effect of slowing down neuronal functioning, and can be very dangerous when taken together. A lot of these anxiolytics and sedative hypnotic drugs are useful as anticonvulsants, so they're useful for suppressing epileptic activity because seizure or epilepsy is excessive synchronized neuronal activity in the brain, also conceptualizes electronic storms in the brain, so it's just way too much neuronal activity in the brain. And so some of these medications, these anticonvulsants, reduce the excessive neuronal activity by increasing the activity of GABA in the brain. So the second group is antipsychotics, and these are used to treat psychosis typically. Psychosis is, in general, the loss of contact with reality. So the most common symptoms of psychosis are hallucinations, or seeing things and hearing things that aren't there, and delusions, which is believing things that are very clearly not true. Antipsychotics are used to treat mostly schizophrenia, bipolar disorder, especially bipolar disorder with psychotic features, and they're also used to treat agitation in older people with dementia, agitation in autism, and obsessive compulsive disorder. There are two main groupings of antipsychotic medications. There's the first generation, or typical antipsychotics, which came around in about the 1950s, and this includes Thorazine, Haldol, Prolixin. These are mostly dopamine antagonists. So antagonists, if you remember, means that they block the transmission of this neurotransmitter. So they block the transmission of dopamine just by blocking this one receptor, the D2 receptor. The benefits of typical antipsychotics is that they're less expensive. They've been manufactured for a long time now, so they're used in a lot of lower resource areas and also like the state mental hospital a lot of times will use these typical antipsychotics for individuals who don't have very good health insurance or not a lot of money in general. The con of these is that they have higher levels of side effects. So antipsychotics in general can be difficult to stay on because they have a lot of really negative and what can be serious side effects. One of the more pronounced one, it's not super common anymore, but used to be a big problem, especially a couple of decades ago, is tardive dyskinesia, which is uncontrollable mouth movements. And you can watch a YouTube video of someone experiencing tardive dyskinesia. Another is Parkinsonian symptoms. So if you remember, Parkinson's disease is caused by not enough dopamine in the nigrostriatal part of the dopamine system. And so by suppressing dopamine, it kind of creates this like Parkinson syndrome, which is known in psych hospitals as the Haldol shuffle. And you can see what that looks like if you follow this YouTube link. Second generation or atypical antipsychotics include clozaril, Zyprexa, Seroquel, and Vega-Geodone. And these are dopamine serotonin antagonists. So they block both the D2 receptors that were blocked by the typical antipsychotics as well as serotonin 2 receptors. Serotonin 2 receptors may act by upregulating D2 receptors later. So the antagonism of serotonin leading to the antagonism of dopamine in these areas. They may target, since there are like 4 dopamine pathways in the brain, there's a possibility that they just target the parts of the brain where dopamine is dysregulated better than the typical antipsychotics. So the benefit, they're generally more effective. Side effects are generally considered less serious, so they're less likely to have these motor side effects. The negative is that they are more expensive, and they are associated with weight gain, and sometimes extremely profound weight gain, which can of course be dangerous. It can cause diabetes and also just a decreased quality of life in individuals who are taking these medications. There's quite a bit of research looking for a 3rd generation or a 4th generation, just more types of antipsychotics that may have fewer side effects and better target other symptoms of schizophrenia. So most of the antipsychotics currently target the positive symptoms of schizophrenia, so the hallucinations and the delusions, and they don't target what we call the negative symptoms of schizophrenia, which is avoiding social contact, a lack of motivation, blunted affect or decreased ability to feel pleasure. A lot of those negative symptoms are not targeted by antipsychotics at this time, and so a lot of people are trying to develop medications that might target the negative symptoms as well. So there's this possible 3rd generation antipsychotic, which is a dopamine partial agonist, they think. They're not totally sure what the mechanism of action is. Abilify is an antipsychotic medication that might fit into this category. And it's believed that it might antagonize dopamine in the mesolimbic pathway, so prevent dopamine in this mesolimbic pathway, this kind of like frontal, this like prefrontal and basal ganglia area, and then be an agonist in the the mesocortical pathway, which there's some belief that there might actually not be enough dopamine in that particular dopamine pathway in schizophrenia. So, kind of as I mentioned at the beginning of this chapter, really complicated. The mechanisms of action are not very simple for a lot of psychotropic psychoactive medications, and similarly the neurotransmitter dysregulation in a lot of psychological disorders is extremely complicated as well. Okay, so group 3 is antidepressants and mood stabilizers. Antidepressants are typically prescribed for depression, but they're also prescribed for a range of psychological disorders. They're kind of add-ons or even like first lines of treatment for a lot of psychological disorders. So people with anxiety will often get antidepressants, people with obsessive compulsive disorder, PTSD, eating disorders. Actually, there's a lot of indication that antidepressants help with anorexia and bulimia, as well as addiction and chronic pain, or pain that is believed to originate in the central nervous system. So antidepressants work as agonists on many different neurotransmitter systems, serotonin being the most common, but as well norepinephrine, histamine, acetylcholine, possibly even dopamine. A lot of antidepressants have negative side effects, including sedation and sexual dysfunction. One of the first types of antidepressants were monoamine oxidase inhibitors, or MAO inhibitors, and these stopped MAO from breaking down serotonin in the axon terminal, so creating a greater amount of serotonin in the axon terminal, which would create more transmission of serotonin. MAO inhibitors had some potentially dangerous side effects. You couldn't eat certain types of foods on them, and so in general, they are not prescribed very frequently anymore. There's also tricyclic antidepressants, which I won't go into much, but they essentially target monoamines as well, so serotonin, dopamine, etc. Trophinil is an example of this. And then second generation antidepressants are the ones that you see more of. You see more people prescribing those. So the most common, or the most well-known one, is selective serotonin reuptake inhibitors, or SSRIs. This includes Prozac, Zoloft, Paxil, Celexa, Lexapro. The mechanism of action is it hasn't been proven yet, but very likely that it inhibits the reuptake of serotonin in the synaptic cleft, as its name insinuates, thereby increasing the serotonin activity at postsynaptic receptors. So it stops the serotonin from being taken back into the presynaptic cell, leaving it in the synaptic cleft longer, which increases the likelihood that more serotonin is going to bind to serotonin receptors on the postsynaptic cell. There was a bit of a controversy a while ago about increased risk in suicide for adolescents and young adults. I think it was specifically it might have been Paxil, where there was people, especially young people, who took Paxil or antidepressants were more likely to commit suicide. And this, it's still not totally clear why this would be, but it could be due to the effects of the drug, so increased agitation when taking the drug. And a lot of people believe it might be due to increased motivation in severely depressed individuals. So if a person who's very depressed is suicidal, and medication brings them to a point where they're just a little less depressed, they might now have the motivation to actually carry out plans of committing suicide. So a lot of times prescribers will be very careful in giving antidepressants to younger individuals for this reason. Okay, so the other type of second generation antidepressants, or I suppose another common type that you'll see, is serotonin norepinephrine reuptake inhibitors. And just as the name suggests, these likely inhibit both the reuptake of serotonin and epinephrine, thereby increasing serotonin and epinephrine activity at postsynaptic receptors. And common ones that you'll see are Cymbalta, Tofacine, and Effexor. And then there's mood stabilizers. So these are typically prescribed for bipolar disorder, which, as most of you probably know, is depression plus mania. Mania being excessive motivation, feelings of euphoria to an extent, and for a long period of time, such that it impairs somebody's life. Some antidepressants can actually induce mania in somebody who has this who has bipolar disorder, and so mood stabilizers are indicated for individuals who have both these very high moods and very low moods. Mood stabilizers in general treat mania better than they treat depression, so they'll bring down the highs, but they don't always bring up the lows as much as one might hope. Types of mood stabilizers include lithium, sodium valproate, Tegretol, Lamictal. Many anticonvulsants are also mood stabilizers, likely because they reduce the neuronal excitability during manic states. So if you remember back when we were talking about anticonvulsants, the proposed mechanism of action is that they reduce GABAergic, they increase GABAergic function and reduce neuronal excitability in general during epileptic states. And there's indication that there's excessive neuronal activity during manic states, and anticonvulsants can kind of bring this down. However, in general, the mechanism of action is largely unknown. In many mood stabilizers, they likely decrease norepinephrine, which there's too much norepinephrine in the brain during mania, and likely increase serotonin a bit too to help with the depression. They also might help to regulate circadian rhythms, or like sleep-wake cycles, which are typically highly dysfunctional in people with bipolar disorder. And they might also increase brain growth factors, so increase brain plasticity and the growth of neurons. If you look over on the right, on the bottom, there are different types of mood stabilizers that have different effects. So some mood stabilizers, such as lithium and valproate, bring down the mania more than they bring up the depression, whereas these other ones might be more likely to bring up the depression and don't have as much of an effect on the mania. And so people who prescribed mood stabilizers will take that into account. We'll decide which mood stabilizer they want to prescribe based on if somebody has more extreme mania and less extreme depression, etc. The fourth group of psychoactive drugs is opioids, or opioid analgesics. An opioid is any chemical that binds to morphine-sensitive brain receptors, or also known as opioid receptors. So it's just essentially any chemical that binds to these opioid receptors is an opioid. Opioid analgesics are opioids with either narcotic or sleep-inducing effects, or pain-relieving or analgesic effects. Opium is a plant that provides raw materials for a lot of the exogenous opioids. So codeine, morphine, and heroin are all synthesized from opium. And then there's endogenous opioids, which are called endorphins. Endorphin is kind of a short form of endogenous morphine. And endorphins are opioid peptides that act like neurotransmitters in the brain. So they have the same effect as morphine, heroin, opium, and codeine. Morphine is extremely potent and very effective, and also extremely addictive. It's actually the most effective analgesic that we know of. We've never been able to synthesize something that's more effective than morphine. Heroin is synthesized from morphine. It is more fat soluble and therefore penetrates the blood-brain barrier more quickly. The faster effect is one reason that heroin is extremely addictive. So it's the most addictive drug that we know of, at least that's in relatively common use. And tolerance to heroin is built very quickly, so it can be a very dangerous drug. Synthetic opioids like hydromorphine, methadone, oxycodone, they're also very addictive when they're used regularly, and this is even when they're used as prescribed. So I think there's kind of a misconception sometimes that anyone who is addicted to pain pills has used them, has abused them in a sense. But some people with chronic pain, they just kind of have to make a hard decision about pain pills, and even when they're prescribed and they're using them as they're prescribed, they can become addicted. Competitive inhibitors are opioid receptor antagonists. So if someone overdoses on an opioid such as morphine, they can take naloxone or naltrexone, and this will block opioid receptors and hopefully prevent somebody from dying from this overdose. So group 5 is called psychotropics. Just a quick note, psychotropic is a term that's often used as just a general term for any psychoactive drug. For the sake of simplicity, we're going to stick to the book's definition of psychotropics, which is stimulants, specifically that affect mental activity, motor activity, arousal, perception, and mood. The first group of psychotropics is behavioral stimulants, which increase motor activity, alertness, and mood. So this includes amphetamine, which is a dopamine agonist. It increases the transmission of dopamine. And it does this by blocking the reuptake of dopamine and also stimulating presynaptic dopamine release. So stimulating the release of vesicles filled with dopamine into the synaptic cleft. Overuse of amphetamine can lead to heart issues, and extreme overuse can lead to psychosis, so hallucinations and delusions. Methamphetamine is an amphetamine derivative, most commonly known as like meth, speed, ice. Obviously, in Hawaii, there are a lot of big problems with meth, and meth has the same general action as amphetamine. ADHD medications are actually typically amphetamines. So Ritalin, for example, is an amphetamine, and its action is that it blocks dopamine and norepinephrine reuptake transporters, thereby increasing norepinephrine and dopamine transmission in the brain. It's associated with improvements in attention and reduced impulsivity. Cocaine comes from the coca shrub, which I think is primarily in South America. This blocks dopamine reuptake transporters, so again, blocks dopamine reuptake, and derivatives such as Novocaine are still used as topical analgesics. So if you're getting like surgery on your skin, like stitches or something like that, or if you're dental surgery, they'll often numb you with Novocaine. And this is actually a derivative of cocaine. Novocaine's action is that it reduces the permeability of the cell to sodium ions and therefore inhibits nerve impulses. So if you remember, in action potentials, sodium ions are rushing in and it inhibits this process. Psychedelics and hallucinogenic stimulants are the next group. These create changes in cognition and sensory perception. At high doses, many stimulants have hallucinogenic effects. These are often referred to as psychedelics. So acetylcholine psychedelics work on the acetylcholine system, and this includes nicotine, which is an agonist. It increases activity at the nicotinic acetylcholine receptor. There are two general types of nicotinic acetylcholine receptors. There's like the muscle type, or also referred to as N1, and this is mostly in the somatic. It's exclusively in the somatic nervous system. And then there's the neuronal type, N2, and this is in the central nervous system, and that's the one that's targeted by nicotine. Activation of these receptors triggers other neurotransmitter function, especially dopamine in the mesolimbic pathway, which is the mechanism by which nicotine becomes addictive. So you can see to the right, this brain picture, the purple pathway is this mesolimbic pathway, if you remember from when we learned about dopamine, and this is the pathway that's associated with addiction. We'll talk about this in a little bit more detail later. Anandamide psychedelics are, anandamide is a endogenous neurotransmitter, so it occurs naturally in the brain, and it's mediated by cannabinoid receptors. So cannabinoid receptors should probably actually be called anandamide receptors, but we discovered cannabinoid affects these receptors before we discovered that this endogenous neurotransmitter anandamide is probably the reason these receptors exist in the brain. So they're called cannabinoid receptors. Anandamide enhances the pleasurable neural response to food. So if you have ever observed someone who is high on cannabis, is more likely to want food or really wants like junk food. Part of the reason for this might be the activation of these anandamide receptors is associated with pleasurable responses to food. It's also found in chocolate. The activation of these receptors has an anxiolytic effect, and cannabidiol may increase as well. So THC, which is the main psychoactive chemical in cannabis, binds to the cannabinoid receptors, so the same receptors as anandamide, in the central nervous system, and it also binds to receptors in glial cells and in the body. THC impairs motor function, impairs memory function, so it's a well known that smoking pot can affect your short-term memory. And it also has anxiolytic effects, so anxiety reducing effects. Glutamate psychedelics are the ones we spoke about before, which were anesthetics. They cause hallucinations, dissociation, and also euphoria. So these are all schizophrenia-like or mania-like symptoms. These include ketamine, PCP, nitrous oxide, and also DXM, which is an active ingredient in a lot of cough syrups. People sometimes abuse it, and it's called robotripping if it's used recreationally. This is the reason that cough syrup, the purchase of cough syrup, especially by underage individuals, is regulated in a lot of states. Part of the action of glutamate psychedelics is the antagonism, so the reduced transmission of glutamate NMDA receptors, and several other neurotransmitter systems in addition to glutamate are affected by this. Okay, so please note that the information on the slide is going to deviate a bit from the text. Mostly I've just characterized or categorized some of the psychedelics differently. I'm putting them all into the category of serotonin psychedelics, or everything on this page. It will go into serotonin psychedelics because they mostly act on serotonin. I think it's a better characterization. Please do note that anytime my slides deviate from the text, we're going to use my slides as the, I don't want to say final word, but any conflicting information, use my slides as the answers for homework or exams. In general, I will try to avoid putting anything on homeworks or exams that is represented differently in my slides in the text. Okay, so moving on to serotonin psychedelics. These mostly act as agonists in the serotonin system, so they mostly increase the transmission of serotonin, but many of them also have effects on norepinephrine and dopamine. The first one, mescaline, is found in several different cacti, including the peyote cactus, and has been used for over 5,000 years in Mexico and parts of South America, a lot of times for like spiritual reasons. It binds to the serotonin 2A receptor. LSD, or acid, also an agonist of several different serotonin receptors and directly increases dopamine transmission as well. Conversely, psilocybin, or psychedelic mushrooms, indirectly increases dopamine transmission, though it's also an agonist of several different serotonin receptors. So LSD and psilocybin have similar neurobiological mechanisms, but they're a little bit different, and similarly the perceptual and psychological effects of these two drugs are relatively similar but also have slight differences. The next one, MDMA, which is also known as ecstasy-E, or in its pure form is known as Molly, often creates euphoria, increased sociability and empathy, and mild hallucination. It's often used as a rave drug, in part because it makes people feel closer to the people around them. And this one also increases the release of serotonin, the release of presynaptic serotonin specifically, as well as norepinephrine and dopamine. Other stimulants include caffeine, which works as an antagonist of the adenosine receptor. Adenosine is a compound that typically creates sedation, slows down the heart rate. So as an antagonist to the adenosine receptor, caffeine kind of inhibits sedation and is associated with a higher heart rate. It indirectly increases dopamine transmission in the striatum as well, which means that it affects the reward system, so people can be both psychologically and physically addicted to caffeine. Other stimulants, and these are not included in the book, but I think they're important. Khat is a stimulant that's grown mostly in the Horn of Africa and the Arabian Peninsula, although it's spreading more, especially to the southern part of Africa. Its effects are increased alertness, mild euphoria, reduced appetite, and in large doses can also cause psychosis. There's a compound of khat called kathione, and this is the active compound that causes these effects. Kathione facilitates dopamine transmission and also inhibits the uptake of epinephrine, norepinephrine, and serotonin. Kathione is actually similar chemically to the antidepressant bupropion or Wellbutrin, which is a type of antidepressant we didn't talk about because there aren't many that have this chemical action. So Wellbutrin is an NDRI, or a norepinephrine dopamine reuptake inhibitor, meaning it inhibits the reuptake of norepinephrine and dopamine, or increases the transmission of norepinephrine and dopamine. Wellbutrin is also used for smoking cessation and ADHD. In its synthetic form can be rather dangerous, actually. Since synthetic kathione is one form of bath salts, which is a type of drug that's several different chemicals are characterized as bath salts, and they're called this because they look kind of like Epsom salt, or like salts that you would put in a bathtub. The problem with synthetic kathione or bath salts is that they're not well regulated, and people end up taking them in doses that they don't expect, or they're cut with something, they're impure. But synthetic kathione does have effects that are somewhat similar to khat. Other stimulants, the betel nut. People in Hawaii might be familiar with this because it's rather prevalent in Melanesia, Micronesia, Southeast Asia, and India. It has a stimulating effect, so it's typically, I think, chewed. It's combined with other things to make it taste better, or to make it easier to be chewed, and it has a stimulating effect that's similar to nicotine. The effect of betel nut is that it's a partial agonist of muscarinic acetylcholine receptors. And unfortunately, there's some indication that it's carcinogenic, cancer-causing, especially mouth cancer, as it's chewed.